Okay, got it. Okay, so our speaker today is Dr. Wenwa Dumyati. Dr. Dumyati is an infectious disease doctor and also a professor of medicine at the University of Rochester Medical Center in New York. Her work focuses on antibiotic resistance, healthcare-associated infections, quality improvement, and antimicrobial stewardship. And she recently led a collaborative in several Rochester hospitals that were successful in reducing the incidence of C. difficile infections by 30%. And she's currently leading a project to reduce C. difficile in several nursing homes through antimicrobial stewardship. Dr. Dumyati, thank you so much for making the time to speak to our group today. And you are no longer on mute. You should be able to speak now. Thank you.
Oh, okay, thank you for the introduction. And next slide. Just as a background, my project to implement antimicrobial stewardship in the nursing homes in the Rochester area is funded by New York State Department of Health, and I have no conflict of interest to declare. Our project primary goals were, next slide. I'm sorry, but I'll go back and say the outline of my presentation includes the following. I'm going to review our experience in implementing antimicrobial stewardship in the nursing homes through a hospital nursing home collaboration. I'm going to describe our successes and challenges and the lesson learned. I'm going to share antimicrobial stewardship tools that we have developed and also include links to tools that are available through different websites. I'm going to discuss options to sustain an antimicrobial stewardship program. In short, it's ASP. Next slide. So our nursing home project, the primary objective were to implement antimicrobial stewardship program in the nursing homes and to reduce the use of quinolone for the treatment of urinary tract infection and pneumonia because of the link of quinolone use with the emergent NAP1027 strain of C. difficile, in addition to the FDA notice regarding the use of quinolone and the related side effects and the increased resistance of many organisms to the quinolones. And the ultimate outcome is to reduce the overall incidence of C. difficile infections. Next. So how did we implement the project? So our setting, Rochester, New York, we have 33 nursing homes. We initially recruited 6, but we expanded to 9, and now we're going forward to 3 additional ones. Our nursing homes tend to be larger than the general nursing home size, so we included nursing homes varying in size between 120 beds to 500 beds. Many of the nursing homes locally have a medical director on site, especially if the nursing home is large. The smaller nursing home, usually the medical director visits the facility once a week. The project started in 2014 and is still ongoing. Now we started and recruited several nursing homes, but we started the antimicrobial stewardship programs one nursing home at a time. And as we moved from one nursing home to the other, we changed some of the tools, we changed the approach, and all depended on the nursing home context and needs. And through our medical director advisory group, we were able to disseminate several of our guidelines and tools. We also have done regional workshops for consultant pharmacists and for infection preventionists and nursing directors. And we also have a lot of our tools and information on our website, and I'll share the link with you on the next several slides. Next. So of note, we started this project before the core elements of antimicrobial stewardship were available. But by this time, I think all of you are familiar with the 7 components, which include leadership support, accountability, drug expertise, choosing a project and an action to improve the use of an antibiotic, maybe for a certain condition or infection, tracking your antibiotic use, reporting your results to staff, and then education. Next. So how did we start? You know, it is very important. If I want to emphasize something, is I have to emphasize that antimicrobial stewardship is a team effort. It cannot be done by just one person at the facility. Everyone has to be on board for this, for something like this to be successful. Many times there is an infection preventionist or medical director or consultant pharmacist who takes the lead, but those leaders need help from other staff in the nursing home. So how did we approach the nursing home, and how did we get the buy-in from the staff and the leadership at those nursing homes? Remember, we started before with the CMS regulation for recommendation for participation, and before the core elements were available. So we had to find a way to attract those nursing homes and let them know that it would be valuable for them to implement a stewardship program. And we use TDIF as an example of why we should improve the use of antibiotic in the nursing home population. Next. So this is how we develop the team. So at each nursing home, our first meeting, including the nursing home administrator, the medical director, the director of nursing, the director of quality, and we also asked that nursing home team members that would have a role in antimicrobial stewardship be present, such as the infection preventionist, nursing home educator, a nurse practitioner or physician assistant, in-house dispense and pharmacy, Libby Dodds-Ashley, who's well known in this field. And we also have a project infection preventionist and a coordinator. So we all work together to implement stewardship at several nursing homes. Next slide. And so this is what we did, and I'll go into more detail as we go through the presentation. First, we collected data. Next. Next. So we went and tried to see where we can get data on antibiotics. And we learned that in the nursing home, very few have an electronic medical administration record. So we had to find other ways to collect data on antibiotic use. And we eventually went and got data from the dispensing pharmacies. So we could summarize the data and show to the nursing home and compare to nursing home to each other to get them interested and engaged. We also went to the microbiology lab to get antibiogram and the number of urine culture. The CDIF data was collected through a CDC emerging infection surveillance that we are doing in the Rochester area. We also advised the nursing home to collect their own data, but we used the data that was already available to us. So our team did most of the legwork at the beginning of the project, which include data summaries. We created educational tools. We created guidelines. And we gave all the tools and the guidelines to the nursing home to implement. And every nursing home implemented differently, depending on who is their champion and who is leading this project. Next. The thing that we found very, very useful in our area is we had 9 medical directors that joined our group, and we met on a regular basis to discuss development of treatment guidelines for common infections, starting with urinary tract infection, diagnosis and treatment, and pneumonia, diagnosis and treatment. And lately, we finished a guideline for treatment of skin and soft tissue infection. So how did we start? By collecting the antibiotics. The dispensing pharmacies, many of them could not give us data that was electronic. Many of it, as you can see, is in paper format. Some of it is in Excel format, but it requires a lot of cleaning. Next. So there are many other ways. So as I mentioned, of collecting data on antibiotic use. And as I mentioned, most of our facility did not have a medication administration data that's electronic, so we couldn't use it. Purchasing data, we tried to use purchasing data from pharmacy, but we realized that a lot of medications for the nursing home are purchased in bulk, and it is not as useful as it is for the hospital. So we used the dispensing data to provide summaries to the nursing home. There's other ways to collect data for antibiotic use, which are manual. You can either do a point prevalence survey of 1 day or maybe 1 week, reviewing every antibiotic that's given and for what indication, or you could look at antibiotic start through the 24-hour report or the infection log. Next. So the dispensing data is what we use. So the dispensing data does not mean that the drug is given, but this is the best data available to us. Next. And so this is an example of the data we shared to the nursing home. So if you went to the nursing home and showed them their use of antibiotic, and you could see that they're the higher user compared to other nursing homes. We adjusted the use by the 1,000 resident days, and we used a measure of days of therapy, which means if you are an individual and you receive an antibiotic for 1 day, that's 1 day of therapy. But if you receive 2 antibiotics on the same day, that's 2 days of therapy. And this measure is very useful because it measures the burden of antibiotic use overall. Next. This is the C. diff data that we had available at the beginning of the surveillance. And you could see the C. diff incidence also was differed between the various nursing homes, but you could also notice that the incidence is lower in 2014 compared to 2013. It is probably related to the ongoing effort that were taking place in the hospital, and we were able to reduce C. diff infection in the 4 hospitals in the Rochester area. Next. So this is kind of what we showed the nursing home. So this is, first of all, we show them the overall use. And then it's very helpful to show them, why are antibiotics used? What's the most common reason that are being used? And in this nursing home, and this was the first nursing home we went to, you see that UTI treatment is the #1 reason for antibiotic. And across nursing homes that we have worked with, it is usually the most common reason for antibiotic. And I highlighted here UTI prophylaxis. You could see that when you give an antibiotic every day for 3 months, this is data for 3-month period, it is cumulative and it adds to the burden of your use. So it's important when you look at the days of therapy and you start to realize that some indications that are chronic really add to your antibiotic burden. Next. We showed them data in a different way. Instead of seeing it by days of therapy, we showed it by number of residents. How many residents are treated for a specific infection? And when you show the data by residents, then you could see that, as has been reported by many studies, UTI, skin and soft tissue infection, and pneumonia are the 3 most common reasons for antibiotic use in the nursing home. And you could see that the number of people that were on prophylaxis was low, but because the prophylaxis is given on a daily basis, this skews the DOT data. Next. And so let's look at the UTIs and see what are people using to treat UTI. And you could see in this nursing home that ciprofloxacin was the #1. antibiotic being used. And so we wanted to understand, why is Cipro being used? Is this the best antibiotic to use in that nursing home? And we needed to gather data from the antibiograms. So next slide. So we went and talked to the microbiology lab and asked them if they could generate an antibiogram, either give us an antibiogram that includes all the culture or one specific for a urine. But as you compare both, you realize that most of the cultures that people obtain in the nursing home are from the urine. So if you're not able to obtain a urine-specific antibiogram, you could just use the general antibiogram, because most of the samples are from urine. We also asked for a number of urine cultures per month, because if we want to improve the testing, it's a very easy measure to follow. If there is a lot of inappropriate testing of the urine, then you can see what happens to the number of tests every month. And while doing this work with the microbiology lab, we asked the nursing home to look at the process of when a culture comes back, who sees the results, where is it recorded, and how is the feedback given to the physician or the nurse practitioner or the physician assistant so they can act on it. So review those processes is very important. Next. And so this is the antibiogram of this facility. And if you look at the ciprofloxacin, almost 40% of the isolate of E. coli, and E. coli in general is the most common etiology for UTI. You can see that ciprofloxacin is really not your best choice, especially if you're going to treat a resident empirically. You're guessing wrong, 40% of the time. We showed them that nitrofurantoin was quite sensitive. We also educated them on the change in the guidelines and the fact that nitrofurantoin can be used in people with renal insufficiency if it's not very severe. So anyone who has a creatinine clearance above 30, nitrofurantoin can be administered to this population. We realized that nitrofurantoin was not in their emergency box, was never ordered. So we had to educate everyone on the availability of this agent and when it could be used and when it should not be used. This nursing home, luckily, trimethylene sulfa was a good agent, but in many nursing homes, the trimethylene sulfa resistance is high as well. It's more than 20%. So again, it cannot be used empirically if the resistance is more than 20%. For the smaller nursing homes, it's very difficult to have enough isolates to create an antibiogram. So what we have done is we went to the lab and say, can you create an antibiogram for the smaller nursing homes that are less than 200 beds, that don't have a population of long-term vent and, critically long-term vent and by the way, we don't have LTAC. So can we create one that's a combination of all the isolate from those nursing homes to create an antibiogram? And you could see that for E. coli, again, which is the most common organism, ciprofloxacin is sensitive in only 67% of the isolate, and nitrofurantoin sensitivity is quite well. And you could also see that the trimethylene sulfa sensitivity is 80%, so just borderline. I also asked the lab to check isolates for E. coli and Enterococcus for sensitivity to fosfomycin, which is an older antibiotic, but it is a very good antibiotic in case your antibiogram shows resistant to multiple agents. The drawback is like the testing for fosfomycin sensitivity is not routinely performed, but it's an agent that also covers for ESBL and might be useful in situations when you're considering of putting an intravenous catheter to give IV antibiotic. If it's a lower urinary tract infection, for example, due to ESBL, you could ask your lab to check for fosfomycin sensitivity. Next. So what is happening in the nursing home to be able to educate and create guidelines. It's very important to understand the process of antibiotic prescribing decision in the nursing home, which is very different as we learned from the hospital. And it usually starts with a clinical situation where there is a change in the condition of the resident, and how the condition, a change in condition, is communicated to the physician, for example, over the phone, really is important. And who evaluated the resident, and what information did they gather before they called is very important for the physician, who's many times not on site, to make a diagnosis and try to decide if to treat or not to treat. So starting by the clinical situation and how well the staff is trained. So we started by reviewing medical records, and we used an assessment of appropriateness of antibiotic for urinary tract infection tool from the CDC website. We tweaked it a little bit to make it more relevant to the residents of the nursing home. And it's very helpful to look in the chart, and you could see that it's not an easy process, because specifically in this picture, we had some information on in an electronic format and some information in the paper chart. The labs were in some place. The notes from the nurses were in paper. The physician notes were recommended as a reason to check a urine culture. So we gathered this information from several nursing homes, and we found, next slide, based on several guidelines for when to test patients to work up for the workup of fever, when should you treat, what are the minimum criteria for initiation of antibiotics, that's usually known by the LOPE criteria. And we also applied the surveillance definition of infection in long-term care facility, known as the revised McGeer criteria. So we applied those criteria to our review for appropriateness of testing and treatment for urinary tract infection. Next slide. So this is what we found, and this is from 3 of the first nursing homes. Next. So first of all, documentation of signs and symptoms of UTI was very poor. Many times you saw just an order to do a urine culture without much documentation on signs and symptoms that are suggestive of an infection. Next. And there were many reasons for testing, and many of those reasons were not for urinary symptoms. We found a lot of testing for a mechanical fall, for confusion, for foul-smelling urine, and generalized weakness. We also saw some notes where the family concerns is what triggered a urine culture. Next. And then we looked at the appropriateness of UTI testing and treatment using the guidelines that are available. And we saw that 2/3 of the urine cultures did not need to be done. 2/3 of the residents that were treated did not need to be treated. And if we apply the McGeer criteria, approximately more than 20% of the residents, only 20% of the residents met those criteria of having a urinary tract infection. Next. And what was if you waited 48 hours, it's very important to reassess and see was the patient what was the reason for the urine culture? Was it for weakness, or was it for confusion? Is the resident still weak? Is the resident still confused? Does the resident have any urinary tract symptoms? And so that was very helpful when we presented to the nursing home. I said, do you ever go and look at the patient before you start the antibiotic when the patient comes back? And I had the stare, blank look in the face, and they said, no, we don't do that. We treat the urine. And I say, you have to treat the patient. You have to look and see, do they have signs and symptoms that would require or suggest that they have an infection. And next slide. So, and then we also saw by reviewing chart that there was no follow-up when an antibiotic is started. There's no follow-up to reassess the patient to see if the patient is responding to treatment, if there's a need to change the duration Or if someone was started empirically, when the culture comes back, there was no follow-up to see if the culture had a resistant organism and the antibiotic needed to be changed. So all these findings were communicated to the physician, to the nurses, and say, this is what's going on, and this is how we can improve your process and reduce the overtreatment, specifically for asymptomatic bacteriuria. Next. And so this is kind of highlighting that it's the positive urine that drives the treatment and not the symptomatic patient that drives the treatment. And we had to educate that you really have to have both symptoms and you have to have a positive culture. But sometimes, many times, you have to start the treatment if you're suspecting that someone has a urinary tract infection, but you have to follow up and make sure that what you have started is appropriate. And if you have started an antibiotic and the culture came back negative, you have to stop. Next. So when we started this project, we asked the nursing home, do they have guidelines for testing of urine? Do they have guidelines for treatment? And none of them did. So based on the data that we collected, it was very obvious that we needed to educate everyone on when should a urine be checked and when should a suspected UTI be treated. So we developed UTI testing and treatment protocol, and we obtained the input for all these protocols of the medical directors. Next. We did a lot of education ourselves. We started educating nursing staff. This is during a session where it's question and answer. We also provided poster, what is asymptomatic bacteriuria and when should you treat and when should you test a patient for a suspected infection. We also made them aware of some tools available online. There is a very good educational program by Dr. Robin Jump, and I have the link. It's specifically for nursing, and it has many small educational slides on how to treat and test for urine, for pneumonia, for skin and soft tissue infection, how to obtain cultures. They're very short courses, and they're very funny. So I recommend their use. We had some difficulty implementing them because many of the nursing homes did not have many computers for nurses to use for training. We also pushed for a better communication using the SBAR and used the SBAR tool to have better documentation of signs and symptoms for urinary tract infection. And with time, as we reviewed more charts, we saw definite improvement in the documentation. Next. We educated medical provider. Again, we shared the finding of our review of the patients that were treated and tested for urinary tract infection. We educated them on the appropriateness and testing and treatment for UTI. We reviewed the antibiogram and how to interpret the antibiogram. We reviewed the treatment guidelines, educated them on the various antibiotics that could be used for the treatment of UTI and how to avoid the use of quinolone as a first-line agent. We also provided pocket cards for treatment. And we, again, recommended improvement of the documentation of signs and symptoms, and we really pushed for a clinical evaluation for every antibiotic prescription and at 48 hours, and what's usually called antibiotic timeout. Next. And so this is an example of a medical staff pocket card, is when to test for UTI. This is one side. Next. And this is another side. We use the combination of the Loeb criteria and the Cernic and Rinka recommendation for treatment for urinary tract infection. Next. And again, we emphasize that it's very important to do a reevaluation. Next. So these pocket cards are available on our website. We also thought it was very important to educate families. We have we had to have session where we educated the frontline staff. How do you communicate to the family the information that their loved one does not need treatment? You know, how do you educate them on the harm and benefit of antibiotics? So we had a pamphlet created, but we also have to educate them on how to communicate this message with the family, which was sometimes not very easy. And the medical director were very supportive. And in a situation where the family was insistent, the medical director had to be involved and talk to the family about avoiding treatment for a case of asymptomatic bacteriuria. And I want to note here, there is a link to the AHRQ website. They have a great nursing home guide that has a lot of toolkits, and I made a presentation based on the available information in the toolkits. Next. Now, the most important thing we found in this is data gathering and data sharing and feedback. Next. So this is an example when we went to a nursing home. We showed them what has happened over the span of the project and where they fit in compared to others, and how they have, if they have improved or not improved, reduced their total use of antibiotics. We also looked specifically for the use of antibiotics for urinary tract infections, since this was specifically our intervention. Next. So you can see here we have measured the number of UTI starts. We could also measure the days of therapy for UTI. And then we found the urine culture rate to be also very helpful, because if you have less urine culturing, there's less positive culture to look at, and less pressure to start treatment because of a positive culture. So you could see in this nursing home where they have up to 100 treatments per quarter, and they went down to almost 60 to 70, and we're still working with them to reduce their use of their testing and treatment for urinary tract infection. Next. And you could see with our guidelines that were established at the beginning of 2015, this nursing home, we started talking to them in 2014, and you could see that the quinolone use really dropped over the period of this project. Next. And I want to highlight some of our experience with the frontline staff. We found that in every nursing home, a champion was the early adopter. And in this nursing home where I showed you the data, the champion was this infection preventionist. And we showed her the data that we collected, and she did decide to start collecting similar data herself. And when she did that, she realized what the problems were. She immediately talked to her educational nurse educator and said, we have to educate our frontline staff when is a patient condition, changing condition, a urinary tract infection, when it's not. In her facility, a lot of testing was for confusion. And she worked with her microbiology lab to get a line list of all the residents that had a urine test so she could review them. She obtained from her pharmacy the line list of patients started on antibiotics, and she had to find out the ones that were specific for the UTI. And she really uncovered by doing that not all the information that she needs is in the 24-hour report. She performed monthly assessment of tested and treated residents for signs and symptoms of UTI, and she used the revised McGeer criteria. And she gave feedback to nurses and in-house medical providers on the appropriateness of testing and treatment. And she did that manually. And next slide is her spreadsheet. And you could see, she was very neat. We took her data and summarized it, but then we realized that, the nursing home needs some way of collecting manually their data, but also the manual collection also to generate graphs that they can share with their staff. So next slide is an example of a tool that we created. We created the tool that included all the indications for antibiotics. So you would start by filling this form when an antibiotic is started. This is a modified form that New York State has used, and I want to show you kind of as an example of what you could do. You could make your own. This is on our website, and a more extensive Excel sheet is also that includes all the infection and all the antibiotic is also on the website. So in this Excel sheet, you can see it starts with an antibiotic name and days, and it includes days of therapy. So this is manual data collection. Our data collection and summary was based on dispensing data, which is different. But we needed to find a way that the nursing home can collect the data and give feedback once we are no longer helping them. So the columns in green are the antibiotics, the name, the unit where the patient resides. Next is all the components of the McGill criteria. Next slide. The urine culture results, and if 48 to 72 hours reassessment was done, and did the antibiotic start fit the McGill criteria. You know, I want to just say something that the McGill criteria are for surveillance and they're not for making treatment decisions, but they're a way that an IP can measure, you know, or assess if this patient fits the surveillance criteria for urinary tract infection. And if you do it over time, you will see a change. Then more people are treated when they have criteria that fit a UTI diagnosis. Next. This Excel sheet also generates how many of the antibiotic starts meet the criteria and how many of the residents were reevaluated at 48 to 72 hours. Next. And it also generates a report like this where you have days of therapy per 1,000 patient days for UTI treatment, but also measures the antibiotic start and the urine culture rate. Next. So I have many champions. It was hard to limit, but I want to highlight that it was done differently in different nursing homes. So in this nursing home, this infection preventionist is very interested in computer and has worked with his IT to create a daily report of antibiotic and culture order. And he also obtained a line list from his dispensing pharmacy of the residents that are on antibiotics. So he could do his own line list and generate a antibiotic days of therapy and rate of UTI treatment. And he used that to educate his staff across his facility on asymptomatic bacteria and antibiotic harm. And he did that with his champion medical director. The medical director focused on educating the physician, nurse practitioner, and physician assistant. He focused on educating the nursing staff. Next. We had also a lot of pharmacist champions. We found more buy-in and more involvement if the pharmacist was a dispensing pharmacist that's on site. However, we had also some very good consultant pharmacists that were able to do the work even though they were not physically there. So one pharmacist at one of the nursing homes decided that every order of quinolone, she would review for appropriateness. And if she found that an alternative can be given, she would recommend it. Another nursing home, the pharmacist reviewed the urine culture results and applied the revised McGill criteria and provided written feedback on duration, if the treatment needs to be stopped, and so forth. And one more example is a collaboration between a consultant pharmacist and an IP. Next. And so this is kind of what they gathered together. The red is what the IP filled, the blue is what the consultant pharmacist filled. So they work together in tandem to gather the information, summarize it, and provide feedback to the providers, to the administration, at QI meeting, and at a antimicrobial stewardship meeting. And next. This is another example. This nursing home we went to, and we were trying to summarize their data, but we found out that all their antibiotic had no indication. So we really could not intervene because we really did not know what they're using the antibiotic for. They had a lot of use of quinolone, but we had no idea what the quinolones were being used for. So this is the infection preventionist and the pharmacist that is dispensing pharmacist and is on site, and a very, very good medical director. And they work together on developing an antibiotic order and tracking form. So this is the form that's completed by hand, and it's sent to the pharmacy to dispense the antibiotic. And if the form does not include all the information, after dispensing the antibiotic, the pharmacist sends it back to the IP that is make sure all the information is collected. And right now, all their antibiotic are every antibiotic has an indication. This champion, next slide, work also with her medical director and the medical staff, and they were all on board. Instead of focusing on only UTI, they focused on all antibiotic use. And they decided that 7 days is what they're going to treat for. The maximum was 7 days for pneumonia, for cellulitis, for UTI. It varied between 5 to 7 days. So just by decreasing the duration of their antibiotic courses, they were able to reduce their total DOT. And next. And yesterday I just met with them, and this was her next step. She has created a way of measuring, of reevaluating the patient, and it's driven by nursing. And so this is a form and that is completed when an antibiotic is ordered. So when an antibiotic is ordered, the nurse fills this form, and she said the antibiotic order, and she puts this form on the clipboard where the 24-hour report is information are present. And this in 48 hours to 72 hours needs to be completed, and the check boxes completed, and that form is kept in the patient's chart when it's done, and a copy is sent to her. So this is how she decided to make sure that a 48 hours to 72 hours review is done. And we have other examples from other nursing homes, but I don't have enough time to tell you all the examples. But it gives you an idea that, you know, people just took the information and everyone, you know, decided what's the best ways to implement the processes that we were recommending. Next. So our successes, I think what was very helpful here is we worked together as a group citywide. I had a medical director that worked with us that I did not specifically provide, you know, work with their nursing home, but they took the tool and disseminate them across their facilities. And everyone now is on board to understand the importance of antimicrobial stewardship. And all the nursing homes we're working with are taking ownership and have implemented almost all the components of the core element of antimicrobial stewardship. We also saw collaboration between different disciplines in and across nursing home. We have IPs between nursing homes calling each other for questions. The nursing home now are working with their dispensing pharmacies that are off-site. They're also working with microbiology lab. They're working with, you know, the nursing home medical director have already a very strong group, but they're also discussing different options for antimicrobial stewardship and what tools and what should we develop as our tools we need to develop to keep this work going. Next. And so this is what happened to our C. diff rate. This is across the 9 nursing homes that we have worked with. You could see that there was already a drop in our C. diff rate before we started our intervention, but this drop continues. Next. And it's interesting to see if you look at when does C. diff develop in relation to a discharge from the hospital. It's well known that the period after discharge from the hospital is a critical period, probably because most of these patients or residents have received antibiotics during hospitalization. So it's very hard to intervene at that point because the patient is already susceptible because of the change in the microbiome from the antibiotic they received in the hospital. And usually that alteration of the microbiome lasts approximately up to 12 weeks, sometimes longer. But you could see that there is a proportion of patients that develop C. diff without having exposure to the hospitalization, and you could see that that rate is going down. Next. So there were some challenges. At the beginning, it was very hard to get the nursing home engaged, especially before the core elements of antimicrobial stewardship were available. But right now, everyone is interested and everyone is knocking on our doors to say, can you please help us to start our program? So, and it was very helpful to have a hospital nursing home collaboration. The hospital have done stewardship for a long time. They have the expertise, they know how to do it, and they really can provide a lot of help at the beginning of a program like we did and I described to you. We find that it's very hard to have dedicated personnel full-time. You know, the infection preventionists have multiple hats. Sometimes you just say, I cannot collect this data. I cannot do this. I cannot do that. I have to just go and take care of something else. Expertise, you know, many of the consultant pharmacists or the dispensing pharmacists have not had antimicrobial stewardship training. We tried to train them. We did a workshop, but there is more need to continue treatment, to continue education. And as you saw, retrieving data is not like in the hospital where you can press the button and get all the antibiotic administered, or get an easy poll of who was treated for urinary tract infection or some other syndrome. So all these things make it a little bit more challenging to do stewardship in the nursing home, but they're not unsurmountable challenges. So because of competing priorities, sometimes, you know, even though an IT might be interested or a medical director or the pharmacists are interested, they have too many things to complete in a time period and could not really dedicate the time that's needed for implementing antimicrobial stewardship. There was a lot of staff turnover, including infection preventionists. So we'd establish a process, we have the data collected, and then a week later, the infection preventionist is no longer there. And as I said, the infection preventionists have a lot of responsibilities. Many really had not a lot of infection control training, so that's another need that we identified. And we identified some reluctance to use new like even an Excel sheet or trying to do reporting into the National Health Safety Network for the C. diff or UTI data. We found that this was challenging. The other challenge is, of course, is the pressure to avoid rehospitalization. Next. So what I suggest is you really have, you know, it's very helpful to obtain assistance if you can from outside help like us, like the hospital who have done this for a long time. But it's also very important to have a nursing home champion and more than one champion, a team working together and everyone is on board. We are lucky that all the nursing homes in our area have very strong medical directors. But it's also important to dedicate time for people to do the work. You need your leadership buy-in and a job description that includes antimicrobial stewardship. We need to involve multiple team members to prevent resilience and flexibility in case of personnel change. This is hard to do, but it's really necessary. It's really necessary that you have many people collecting data, many people reporting on the data, and it's not just one person, the infection preventionist or the pharmacist. And the antimicrobial stewardship needs to be integrated into the daily workflow and the nursing home quality and performance improvement QAPI. Next. I want to thank all my help here, my hospital team. I have Christina Felton, who's the coordinator, Gail Kuhlman, the infection preventionist, Grant Barney, who's also coordinating this project, and of course, Elizabeth Ashley, who is the very experienced pharmacist, antimicrobial stewardship pharmacist. I have created guidelines and tools with the help of multiple physicians. I had received a lot of help from dispensing pharmacy, the nursing homes, and our emerging infection prevention CDIS surveillance team to give me the CDIS data. Next. These are some links to additional tools and information. The AHRQ website is very helpful. It's called Nursing Home Antimicrobial Stewardship Guide. And I have the link to our website where we have the tool I described to you. Next. We have time for questions. I guess we have only 5 minutes for questions. I'm sorry it took longer.
Dr. Domyati, thank you so much. That was a fantastic presentation and really, really impressive work that you've done. So I want to encourage the attendees to ask any questions that they may have in the chat box. Currently, there are no questions, so I wanted to go ahead and just ask a few questions. So I'm wondering, was this considered a research project, and did you need to get an IRB approval or exception?
We applied for IRB approval, and it is expedited because it's low risk. But you could also, use it as a quality improvement. But at the university, they made it expedited because we were collecting patient data.
Okay, yeah, thanks. That's something that we always take into account when we're collecting data. Did you have outside data collectors going into these facilities? For example, doing the chart review?
It was done by us, which is, a member of 4 people. Yeah. So it's me, the infection preventionist, and the coordinator. We were the chart reviewer. But now we're in the 4th year of the project, and the chart review is mostly done by the nursing home themselves.
Okay. And I'm really glad that you brought attention to the AHRQ toolkit. I've looked through that and think it's absolutely fantastic. And especially the educational tools, both for family and for staff.
Right.
And as a matter of fact, we actually have Dr. Robin Jump on our schedule to speak to this group in a couple of months. So.
Oh, great. That's great.
Yeah, we're looking forward to that. But I know that it's difficult for nursing homes to kind of put it all together. So I'm very, very interested in seeing the tools by looking at your website and seeing the actual guidelines that you used for these nursing homes. So again, to the audience, any questions for Dr. Domyati?
So I think what I'm presented is probably overwhelming, but we started small. If I had to give advice for nursing homes that haven't started, start small. For example, the consultant pharmacist that works with infection prevention, what she did, she just took 2 units in one nursing home and decided to look at treatment for UTIs. Just 2 units. And by doing that, she really realized what needed to be done. She realized that we need to educate frontline staff about asymptomatic bacteria. We need to create posters, and she also realized that she needed to create treatment guidelines, also emphasizing what agent and duration. So start by something like maybe 1 or 2 units and gather some data. It's very eye-opening when you look at the chart and gather data. It makes you aware what needs to be done. Maybe you're perfect, you don't need to change, but you always can find, where do you need to improve?
Yeah, absolutely. I don't know if you've seen our Jumpstart Stewardship workbook. It's a step-by-step guide for implementing stewardship in a nursing home. And that too, I think, can be very overwhelming when there are so many competing priorities. But what maybe we haven't emphasized enough is in implementing a program, you may not be able to hit all the 7 core elements of stewardship, but it still is worthwhile to start with a few, like performing the education or,
Right.
or gathering the data just to see where you are. So yeah,
Right.
we think,
you know, and what I presented is work that has been done over 3 years. Nothing happened very quickly. You know, this nursing home that I showed you that did the 48 hours review, it took them almost a year to just create that order sheet. So it takes time, but if, you know, just get started and see what you really need to do. For them, that was the most important thing, is to understand why are antibiotics being used. So their intervention was just, let's focus on documentation of indication. That's a start. That will fit the action in the core element.
Right. Gosh, I had one more question for you. Oh, I know. You know, one of the things that the nursing homes have asked about, and a prior speaker actually gave some examples of, you know, you take the SBAR, but then when you actually go to speak to the provider who's probably off-site, did you recommend some scripting for that?
You know, we tried very hard to make every nursing home use the SBAR, but every nursing home did it differently. And some use the Interact tools, and some use their own version. They create their own version for communication. We have not audited to see how well it's done. When you talk to people, they say, we do it, but I'm not sure if it's 100% done. I cannot really report on it. I had more difficulty getting the nursing staff to do the education I recommended, or to use the tool I recommended. But I think with time, everyone is realizing that all these tools and communication tools and documentation is really crucial to improve that whole process of antibiotic prescribing. Because it starts with the frontline staff. They're the one that notice the change in condition, and how they communicate this information or document makes a big difference when you, as a physician or a nurse practitioner, has to make a decision, especially if you're not on site.
Yeah, great.